All right, let's kick it off. Good morning or good afternoon, depending on where you are today. I'm especially excited about our discussion this morning as we're looking at expression through a different lens. We regularly discuss speech in the context of the social sciences and humanities, but its intersection with medicine and health sciences is less often explored. And what more apt time to focus on this intersection than during a global pandemic? There's so much to learn from the work that health sciences has had to do. They face an urgency that the undergraduate studies do not face. And while their perspective is unique, the lessons learned can be applied to challenges that we all face in higher education. With that, I want to start by talking with Dr. Renee Navarro, the Vice Chancellor of Diversity and Outreach at UCSF. In this role, Dr. Navarro collaborates with faculty, staff, and students to develop and carry out a strategic plan for diversity and inclusion at the campus and in recruitment and retention of faculty, students, trainees, and staff. After completing medical school and residency at UCSF, Dr. Navarro joined the anesthesia faculty in 1990. Prior to medical school, she completed a PharmD at the University of the Pacific and is a registered pharmacist as well. She is currently a professor of anesthesia and perioperative care at San Francisco General Hospital, where she served as past perioperative medical director and chief of staff. Dr. Navarro was an associate dean of academic affairs in the School of Medicine and also serves as an anesthesia career advisor. Dr. Navarro became the first UCSF Director of Academic Diversity in September 2007. We are extremely pleased to have you join us today. I wanted to ask Renee to talk a little bit about the history of activism at UCSF. I know that most people are very familiar with how Berkeley and other campuses were very active during the anti-war movement in the 70s, but I know that I was unfamiliar with the role of the medical school in activism. So I'm going to turn it to you, Renee, for a little history lesson.
Thank you, Michelle, and thank you for this invitation and opportunity to speak on these important issues. So UCSF is unique within the UC system and within many systems because we are a health science only campus. We have schools of dentistry, pharmacy, nursing, medicine, and a graduate division without the benefit of an undergraduate class. So we are wholly focused on health, research and educating the next generation of healthcare providers. And UCSF has a long history of advocacy collectively leading to significant changes. Dating back to the 1960s, late in the 1960s, actually after the death of Martin Luther King, a group of predominantly African Americans and Latinx individuals came together. And these were service workers working primarily in the areas of housekeeping and in the cafeteria. And at UCSF, they were working throughout the institution, but were relegated to the basement for their own meals and to use the restroom. And they called themselves the Basement People, but later formed the UCSF Black Caucus. The Black Caucus has been in existence for over 50 years and is the longest employee resource group within the UC system. So the group actually went on strike, demanding better care for themselves as it related to uniforms and recognition, et cetera. But they also demanded that UC increase the number of underrepresented minorities, students, and staff. And Dr. Phil Lee was our chancellor at the time, and he had just come to UCSF following his role in Health and Human Services, where he integrated the hospitals within the South as a result of the introduction of Medicare. When he came to San Francisco, however, he was shocked to hear that UCSF was called the Plantation on the Hill, largely for some of these discriminatory racist things that were happening to people of color. So the Black Caucus is really the shoulders upon which a lot of the additional movements have stood over the test of time. Response, it was one of the reasons why I later had an opportunity to serve to be a medical student at UCSF, and I learned this history, and we share this history with our incoming students so they understand and appreciate the shoulders upon which we are standing. Further, years along, our students then came together in about the 2000 and formed a Health Unity Board. And the Health Unity Board was formed by students across interprofessionally who were concerned about the fact that we lacked a multicultural resource center on campus, and we lacked an executive voice as it related to issues of diversity, equity, and inclusion. And as a result of their activism, the first Vice Chancellor's role was identified, and I had the opportunity to serve. I have the opportunity to serve as the inaugural Vice Chancellor for diversity and outreach at UCSF. Fast forward, and we established the Multicultural Resource Center within the first 18 months of my being the Vice Chancellor. Additionally, following murders of African Americans, our students came together, again, interdisciplinarily, but led by the students in the School of Medicine, to form the White Coats for Black Lives. And the White Coats for Black Lives really reflects the privilege that having a white coat provides, and the responsibility then that you have to consider as well. And our students held a die-in in December of 2009, and really following their activism, we regrouped, had a large retreat of hundreds of leaders on campus, and developed the Differences Matter initiative in the School of Medicine, which is a very focused initiative we've been implementing, which covers all aspects from recruitment, retention, to climate issues, education and training across our campus, how we conduct research. It's a very comprehensive way of how we can work to improve both access to our institution and the diversity and the equity within our institution. And so activism has truly led the way at UCSF and pushes us forward. Fast forward to 2020, where we do sit at the crossroads of both the pandemic of COVID-19 and its disproportionate impact on Black and other people, Indigenous people of color, and looking at that, and then also the racial inequities that we see, we are forced as a nation and really as an institution to look very carefully at how do we go about dismantling systemic racism as it impacts our institution, as both we know institutions of higher education as well as healthcare are impacted by systemic racism. So the fight it moves on, and we are really responding to and moving forward as an institution to dismantle some of these systems that have really been complicit in racism over the years. I'll stop there.
No, thank you so much, Renee. I find it to be both a very hopeful and inspirational story, and to see the kind of the holistic work that's happening at UCSF, I think is a model, not just for UC campuses, but for all campuses. So Renee touched on a lot of issues, a lot of big issues, including systematic racism. And when I've spoken with the three of you, in preparation for today, each of you mentioned sort of hierarchy, tradition, power dynamics, short coats, long coats, a lot of these things that are endemic to the medical world. And I'd like to ask each of you to speak a little bit to that. I'm going to start by asking Suneil to speak to these issues. Dr. Koliwad, let me introduce him. Everybody has such an esteemed background. Dr. Koliwad is the Associate Professor of Medicine and Chief of Endocrinology and Metabolism, also at UCSF. I'm proud to share that he's also a member of the Center's Academic Advisory Board. Dr. Koliwad is an investigator in the UCSF Diabetes Center, holding the Gerald Grodsky PhD JAB Chair in Diabetes Research and the Mount Zion Distinguished Professorship in Endocrinology. He regularly attends on the diabetes and endocrinology services at UCSF, where he trains medical students, nursing students, residents, and fellows. Dr. Koliwad earned his PhD and MD degrees from Baylor College of Medicine in Houston, Texas. After a chief residency there, he arrived at UCSF, where he completed a clinical fellowship in endocrinology and a research fellowship at the J. David Gladstone Institute of Cardiovascular Disease. As a faculty member at UCSF, Dr. Koliwad's lab focuses on how nutrients, inflammation, and metabolism intersect to produce common diseases such as obesity and diabetes that exact a huge toll on minority and other vulnerable populations. All right, with that introduction, Suneil, could you start us off by talking about how some of these power dynamics impact the ability of medical students in particular to have a voice and use their voice?
Absolutely. Thanks, Michelle, and thanks, Renee, for that historical perspective. I am a faculty member at that same institution who's working and living in the context of that history and where we are today. And as I look at the issues that Renee brought up in her historical narrative of UCSF's experience, I can't help but think that there are two parallel stories in medicine that have really set us up to where we are today. One has to do with the development of medical training in the United States in the first place, which is to say that it began in the 1800s largely as an apprenticeship-based tradition, and the power hierarchy in a one-to-one apprentice and mentor-based learning modality couldn't be more stark. And then as we transition into the 19th century and our understanding of human anatomy, its relationship with physiology, how cells work, and how therefore pathophysiology of disease comes about, that apprenticeship-based approach sort of meshed with this newfound scientific understanding and the modern, such as it is now, the current hospital-based academic training infrastructure came into being. And some of the words that we actually apply to that training infrastructure are really interesting ones. Resident. Well, what does resident mean? You're living in the place where you work. There's no sort of more clear example of an inability to feel completely free with your daily work life as a trainee than the term resident. Even lower on the totem pole than that is intern. And think of all the other ways we use the term intern or interned, and whether that has a positive connotation. And you can start to see how some of the moorings on which modern medicine is based actually have some pretty interesting historical elements to them. And that then, if you think about the evolution of medicine through the 20th century, you come to a very clear node. One has to do with infectious disease control and vaccines, and the other one has to do with the discovery of DNA and the molecular biology revolution. We are still 30 years into the shadow of all the benefits that came from Watson and Crick's discovery and molecular biology. Now, what I will say is that revolution then influenced the next several decades of medicine and medical training. But right now, what we're realizing is that not every revolution in medicine has to come from scientific discoveries. Revolutions in medicine can also come from societal shifts and our newfound and better views about how we need to be interacting as members of society and how we need to be thinking about ourselves in our profession in terms of how we train folks. And my hope is that we are going to see the next 30 years reflect the shadows of these revolutionary times that we find ourselves in now. And to that end, I'm very happy to be a faculty member at an institution like UCSF who's just trying to figure it out and really see if we can get this right at a time in our history when we know that there are a lot of fundamental shifts going on, just like the fundamental shifts that took place right after Watson and Crick made their astounding discoveries. And I think that, it's no less astounding what's happening right now.
Thank you. That's a terrific perspective. And I'm going to turn to our third esteemed panelist, who is not from UCSF, but is from another great UC Irvine, and that's Dr. Xavier Hernandez, who's the Diversity and Inclusion Programs Officer at the UC Irvine College of Health Sciences. He is also a recipient of a Voice Grant from the Center. In addition to being an alumnus of UCI, he holds an MA in Asian American Studies from San Francisco State University and a PhD in Educational Policy Studies from the University of Illinois, Champaign-Urbana. Previously, he served as the Director of Asian American and Asian Resources and a faculty member at the Cultural Center at Purdue University. He has experience as a faculty member at the University of Illinois and at Purdue, respectively. His academic publications include articles in Race, Ethnicity, and Education, the Journal of Diversity in Higher Education, and the co-authored monograph, Asian Americans in Higher Ed, Changing New Realities. So now, Xavier, I'm going to turn to you and for you to share with us from your perspective about some of the hierarchy and power dynamics that impact expression in health sciences.
Thank you. Thank you. Thank you everyone for joining us today. And thank you for Dr. Navarro and Dr. Koliwad for your, very robust history of UCSF. What really struck me about the history of activism that's been discussed, which I see as, again, as an alumnus of UCI, as a Southern California native, is something that we deal with on the Irvine campus, is what is perceived as a lack of history of activism here in UCI, and I would say in the larger Orange County area. I say perceived because I don't think that that's necessarily true. You know, UC Irvine established the first cross-cultural center in the UC system. But I think that just the perception, particularly of South Orange County as this affluent suburb reality TV center of, you know, the country, has, you know, affected how many students feel that their activism will be received. And quite frankly, it is definitely something that our medical center and our School of Medicine faculty really try to combat during admissions season. We get a lot of questions about, you know, if I come to UCI, what is the patient population that I will be serving? And there are concerns about, again, the sort of, you know, climate that may surround activism at the, particularly here in Irvine. But, you know, for us, part of our discussions that we have with folks is that we, you know, point to our principles of free speech and inclusive excellence that guide the university's entire enterprise, which includes the medical center, right? So again, it's a very holistic and collaborative effort that we are able to point to say that, you know, the UC system and UC Irvine do welcome free speech, and, you know, these exercises of activism, right? That these are things that are encouraged and welcomed, and the dialogue that comes with it is very much a part of our university. You know, I think, you know, part of that also comes along with educating folks about what the complete demographics of Orange County are. You know, the medical center, quite frankly, lies pretty center into between South and North Orange County, which provide very different demographics and patient populations for our trainees to serve. And I think that also part of our role in encouraging students to engage in dialogue and activism is really emphasizing the role of people beyond what's perceived as the immediate hierarchy that Suneil was describing. So, you know, whereas some people may see their entire, I guess, world as their one supervisor in their lab or, you know, in their program, we hope to establish that, you know, we as the Office of Diversity and Inclusion are part of a larger network of folks, staff, faculty, students, who contribute to diversity and inclusion efforts on campus, so that there are allies in all different pockets of the university that folks can turn to address these issues. And it's not just thinking about the one person who is immediately in front of you, but thinking about the entire university as a collaborative network of folks to have these discussions with.
Thanks, Xavier. I imagine, Renee, you have some thoughts you might like to share about power dynamics. Before you do that, I just want to remind participants that you can enter questions for the panelists into the Q&A, and I encourage you to do that. All right, and then Renee, if you want to add any thoughts about hierarchy.
Well, you know that hierarchies exist in our institutions, as Suneil said so well, are really predicated on those hierarchies. And in order for us to have true equity and inclusion, we have to start to disrupt some of that. And when I talk about systemic changes that are going to last over time, I talk in terms of strategic disruption of the status quo, and having people be mindful, in fact, of those hierarchies and mindful of their sort of affinity biases, right? As elite institutions, we have affinity biases for those who are like us. And that, I think, stems from this notion of an apprentice. You're going to find this apprentice that looks like you or reminds you of your younger self. Well, as a Black woman in medicine, there were few before me who would look at me and say that, right? Because there were very few role models and faculty, et cetera, at the time that I came through UCSF. And still we struggle to have sort of representational diversity across the full spectrum of research, clinical care, and teaching within our institution. So therefore, you really have to start thinking differently about how do I mentor across differences? You know, when we introduced mentoring programs, for example, for our faculty, We have to teach our senior faculty to mentor women, to mentor underrepresented minority groups, to try to have a greater understanding of where your potential unconscious biases might lie in those relationships. We have to disrupt the ways in which we think about science in some ways. We know that we get better scientific questions if we have diverse teams contributing to the questions. We know that we can't take data that involve just white research participants and try to apply it broadly to all individuals, or studies involving just men and cardiovascular disease doesn't necessarily apply to how women present with cardiovascular disease. So we have to have a mindset of kind of continuous equity and improvement, and part of that is to dismantle some of these hierarchies to allow a better exchange of information and recognize that we are matrixed organizations. Our students teach us a whole lot, and when we sit back and let them tell us about the current state of being for individuals, then we learn a lot as faculty and leaders in our institution. So we're trying to be mindful of that, of both our responsibility, but for professionalism and our educational responsibility, but also our obligation to listen and to let some of the young folks lead us as well within these organizations. And that's the approach we try to take.
Thank you. Disrupting the status quo is a big task. And I think I'd like to ask each of you how, your institution or you in your role are helping address some of these challenges. And Xavier, why don't we start with you? I don't know if you want to talk about UCI generally, if you want to talk about your voice grant.
Sure. So yeah, the voice grant that I've been awarded deals with our proposed project, which we've tentatively titled Acting Against Intolerance, which is a workshop that would teach our staff and faculty and our trainees as well to how to deal with patients who may be acting hostile toward them based on their identity or questioning their qualifications and things of that nature. We've definitely heard lots of narratives. Our office was only established about 2 years ago, a little 2.5 years ago. And a lot of the narratives that we've described, and this is a trend really across academic medicine, is what can we do to, protect our trainees, staff, and faculty from, folks who may be mistreating them, whether that's patients, their visitors, et cetera. So that's, our mission. And I think in terms of disrupting the status quo, what we're really trying to do in a broader sense is educate folks to understand that these issues of speech and inclusion are not these value added or extracurricular things to our training and our mission, but they are part and parcel to them. Again, thinking about just from a broader student life perspective in higher education, oftentimes things like cultural organizations or affinity groups are thought of as just extracurricular gold star type of activities, icing on the cake. But we want to let people know that these issues of diversity and inclusion, they are the cake, that people really need to understand how to hold others accountable, how to use one's position of managerial authority to make sure that you support those who directly report to you, how to make sure that you follow up with people to make sure that they've been debriefed on how a particular situation went. So those are the practical skills that our project will tackle. How do you, diffuse a situation without being hostile? How do you debrief a situation without necessarily resurfacing and re-triggering all that trauma? And again, really scaling up to that status quo of these are things that are essential to our mission. Without these things, we would not be able to fulfill our mission as a university or as a medical center.
Thank you. I really like how you differentiated from the icing and the cake, and that really it's not the extra, it's the focus. So as I turn kind of to this question about what institutions are doing, we have a really interesting question in the queue that I'd like to share. It basically says we have innumerable cases, often senior white male faculty members who are responsible for disruptive behavior, bullying, other misconduct, even discrimination and harassment, who escape culpability because those who have the information are fearful of retaliation. How can we disrupt this vicious cycle? What can we do about faculty discipline processes to enforce behavioral norms? I'm going to turn to Renee, and then we'll turn to Suneil.
So I'll address the question first, and then I'll talk a little bit about how we're thinking about this comprehensively at UCSF. So in my shop, I have both compliance as it relates to Title IX and Title VII. Therefore, I am charged with doing investigations of individuals where there is disruptive behavior involved. And I think the thing is that your institution has to have the courage to be willing to go in and say, you know, I don't care how many grants or whatever the case may be or your status, that this is unacceptable behavior. So you first have to define, you know, what's unacceptable behavior. Your principles of community in part help to define that, but then you have to have that accountability and you have to be able to respond. Now I can say that there have been senior established leaders at UCSF who we've investigated and had to issue sanctions. The sanctions are limited, of course, by the academic senate defined sanctions for faculty who are found in violation of the faculty code of conduct, but those sanctions include up to and including termination, which, you know, we have done as a result of violation of policies with disruptive behavior that is discriminatory and or harassing. So if the institution has the courage to do that, then that certainly can happen. It doesn't happen overnight, right? It's the strategic disruption of the status quo. And as we embarked on the strategic plan at UCSF, which is a roadmap to inclusive excellence, back in 2013, it was really soup to nuts. And how do we think about, you know, the people in our institution? How do we think about the climate, the curriculum, research, and leadership? And initiatives around understanding a common language around diversity, equity, and inclusion started with leadership training. The Unconscious Bias Initiative was rolled out with the Chancellor's Cabinet being the first group to take this training and then sort of, you know, disseminated it across the campus community. So you have to have that understanding and that education and training as a foundation. It increases your capacity to then engage in more challenging conversations. So now as we're facing issues of systemic racism and anti-Black racism, people understand that, right? We've had years of our leaders actually doing that training. The next year we did white privilege and brought in an external speaker to talk about that. So we've done a series of things so that the leadership stays informed and in tune and really are driving these changes themselves. And that has to be one of the ways in which you approach it. And then you introduce systems changes, right? So faculty hiring, staff hiring, it can't be the same way. We have faculty equity advisors, staff equity advisors that disrupt the status quo process, introduce evidence-based strategies that are shown to increase the fairness and equity of the process. And those are the ways in which you can go system by system through promotion. When we looked at who gets AOA at UCSF School of Medicine and found that you can have the same test scores and same evaluations, but if you were Black, you were less likely to be selected for AOA. So even changing our criteria. So you have to critically be willing to have the courage to critically look at all of these systems and then change it when you find that they are biased.
Thank you. It sounds like, you know, courage is the underpinning of these things. Suneil, I would be interested in your, you know, speaking either to that question, but also as someone who, you know, is the head of a lab, what things you are personally doing. And then I'll put all the panelists on notice. We had an interesting question about imposter syndrome. Someone who asked about first-year medical students experiencing that and how we might assist with that. Okay, go ahead, Suneil.
Sure, great. So I'll say that the answers are twofold in terms of my thought process. One is, as a person of color myself and as the son of immigrants, I know what it feels like to wonder how my mentors view me when I was coming up through my training. Fundamentally, question whether they felt like I had the promise to do what they're doing or not. And the inability to speak up and ask them that very fundamental question. I felt that as a scientific trainee, and I felt that as a clinical trainee as well. And so I think part of the solution here is to populate our ranks with more people over time who have had those experiences that mirror the ones expressed by the most vulnerable segment of our own community, so that we have advocates built into our system. I think we're not necessarily there yet, but we are definitely moving or trying to move in the right direction. I think another example of this is the white coat itself. And I will expound on that in just a second. But I'll say that the other half of what we need to be doing in medicine has to do with the fact that our calling, if you want to still use that term, to be focused on key diseases and key health issues in our society also now intersects with diversity, issues of inclusion, issues of access, issues of equity in our society more broadly. And by empowering voices within our community, we actually position our own profession better able to address those big fundamental health related issues in the society more broadly. So I see these issues as the leader of a division. And one of the diseases that we tackle in my division is diabetes. And diabetes could be the exemplar, poster child for social determinants of health and disparities in health in our country and perhaps across the world. So we need to have a profession that understands those disparities and those issues of health equity, as well as they understand the pathophysiology of diabetes, because each of these things play significant roles in determining who gets this disease and whether it progresses. And so with respect to the white coat, I'll tell you historically, I used to never, and still often really don't ever wear one, because I didn't want to give my patients, even though I've experienced patients calling me names based on my own race throughout my career here and there, ever make my patients feel like there was a barrier between me and what I do and what I know and them and their lives. And I felt sometimes during my training that the coat actually placed that barrier between us. However, we have a white coat ceremony at UCSF, and many institutions around the country do the same. And I've come to realize over the last 20 years or so that white coat has a completely independent meaning that is really elegant and glorious and worth championing. And that is to say that there are vulnerable individuals and people who have not had a voice, for whom that white coat and putting it on for the first time makes them feel like they now have one. And our job is to allow those voices to emerge within our community as well. And so I think that we're seeing this flux inside the profession, and also in terms of our ability to interact with the community as a whole that we're tasked to care for, based on these issues of inclusion, diversity, and equity. And finally, I'll say, as a laboratory head and somebody who's mentoring people to be scientists, it is probably nowhere more evident, this issue of diversity, than in science. I mean, you really do have a very homogeneous infrastructure of senior scientists around the country in the biomedical sciences, perhaps even in particular. And one of the things that I think we all need to be doing is creating, identifying opportunities and approaches to find, retain, and support diverse individuals who would like to become scientists. And that is something that we are still trying to teach our faculty how to do. And I think it's exactly what Renee said. It's how do you mentor across diversity? And there's a skill set there. And I think that the basic sciences and maybe even the translational sciences are just starting to get the vocabulary around that skill set, much less, become experts in that skill set more fully.
Thanks. I have to say, I wish all of the doctors that I see were like you, Suneil. So Xavier is going to speak to one of the questions that came up about imposter syndrome. I think that's something that everybody can relate to. You don't have to be in medicine. So go ahead,
Yeah.
Xavier.
I mean, it on the one hand, it is, sort of a very difficult question in terms of imposter syndrome. It's sort of asking, how do we help students, embrace their own self-efficacy and their own self-esteem. But I think that, again, very broadly, one strategy to think about is that, diversity or, diverse folks in your institution should not solely be relegated to times of crisis or framed in terms of deficit or, commemorative months and weeks. So for example, again, if the only time you're contacting, people of identity X is when like that identity X is in the national news for some crisis, that really frames that identity in a particular way, right? That is around crisis and deficit, or again, even if the only time you celebrate your LGBTQ patients is during Pride Month, or the only time you celebrate, your, again, insert identity here and there, right? If the only time you think about these is in these sort of rigid boundaries, then of course people will see their identities again as extraneous to your institution or its curriculum or its mission. So I think that there are ways that you can still celebrate diversity and inclusion throughout the year, right? Whether that be through spotlighting people who are doing research on groundbreaking communities or areas that are not part of the status quo in your institution or your curricula. Putting spotlight on people who win awards in their various professional associations. Again, even things as simple as working with marketing to change your billboards and brochures and posters that are hanging up around your institution. There are lots of micro level things that can add up to building a culture where people feel like they belong, both at individual level and institutional level.
I just want to add to that, and I think you're absolutely right, Xavier, in that you have to sort of normalize how people feel, especially incoming students. And so we've retooled our whole orientation. The first 2 days is about belonging, and that it normalizes. It's normal for you to feel like you have imposter syndrome. It's normal for you to feel like somehow you slipped through and got in. And we share the experiences of senior students with those who are just coming into the institution, just to help people understand that this is kind of a normal part of the transition and you do belong, and here's why you belong and why you're so important to our institution. So we have an institutional responsibility to assure folks that we're comprehensive and we selected the best and the brightest and they deserve to be a part of our community. So I think those are right on par with what you were saying, Xavier.
Thank you. Another question from a participant has to do with, obviously we care about inclusion, and these important issues from an equity perspective, but someone's asking if one of the panelists can comment on how diversity and inclusion contribute to advancing medical knowledge and practice as an additional reason to highlight the importance. And I think Suneil wanted to speak to that.
Yeah, just at least to start off the discussion. I touched on it in my comments on diabetes, but I think more broadly, one of the really interesting things and very, I think, encouraging shifts that we've seen in at least medical trainees and perhaps across our entire professional architecture more broadly, is that whereas 30 years ago and before, individuals who express an interest to go into medicine and related health sciences did so oftentimes because of their fundamental interest in biology and their fundamental interest in translating biology towards health and the human body and its ailments. We've now seen a shift such that people who want to go to medical school, at least in the first place, are doing so primarily because they see areas of injustice in society that can be best tackled by studying medicine and using that lens to try to address these injustices. And we're seeing the first generation come through the full spectrum of the training time period who started out coming into medical school with that idea in mind. And we are the ones changing how we do things to adapt to that shifting demographic of people who are entering our profession. And we're not done with that shift. But I think when we get through this shift, it's going to be a really, really cool change that we see. I'm very much looking forward to seeing what happens in that regard. And to the question then, with respect to these diseases that disparately affect certain segments of the population versus others, we're better able to address those problems because our trainees and their skill set actually contain skills that the mentors who teach them about the human body and how it works don't have. So as Renee said at the very beginning, the students, in many ways are teaching the teachers, and we are benefiting from their coming to our universities to learn medicine. And that sort of ground up re-education of the way we do things is directly benefiting our patients. For example, we roll out web and video-based approaches to manage diseases like diabetes and hypertension. And we see that many of our patients don't have internet access that's good enough for them to get those services through the internet, like some of these high-end tools might be able to provide to other parts of the population. And so our students and our residents are the ones who came up with phone-based approaches to accomplish the same things, including interpretation services and all the rest. And we're seeing that in the context of COVID too, where it's the students that are stepping up, providing childcare services and other important elements to allow us to continue to do our work. And so I think that absolutely the idea is that this issue of diversity, inclusiveness, and equity is directly going to benefit our patients by realigning the way we think as physicians going forward.
No, thank you. The idea of ground up innovation is so exciting. Renee or Xavier, do either of you want to add to those comments before we move on to a different topic? No?
Perfect.
Okay, so another question has to do with Title IX, which I'm gonna let Renee take since she's in charge of compliance. And so for those of you that aren't aware, there's been a lot of changes with Title IX over the last 12 months. And I think August 14th was a big deadline. And so maybe Renee can speak to how you're managing that at your institution.
Free speech vote. So August 14th, there was a requirement for new regulations, as has been alluded to, for Title IX. And the purpose of the new regulations and the clarity that came from the national administration was that, in fact, they wanted more rights for those who were respondents. And therefore, the new regulations changed the ways in which we are allowed to investigate and sanction individuals who are accused of violating the policy as it relates to sexual harassment and sexual violence. And in that policy, the procedural parts allow for the respondent to contest the investigation, to have face-to-face cross-examination from their accusers, which is re-traumatizing to individuals who have experienced sexual harassment, sexual trauma. So yes, we, by law, by federal statute, have to be compliant, and we have changed all of our processes over the course of the last several months to reach compliance with those rules. But we are hopeful that come January 2021, we'll get some stay to that, and we will have some rebalancing of the Title IX regulations. The other thing we're working on as it relates to federal statutes around harassment and discrimination is that we also have Title VII, which relates to harassment and discrimination on the basis of race, national origin, LGBT status, etc. And we want a leveling up, because harassment and discrimination is harassment and discrimination. And for too long, we've spent appropriate time on sexual harassment and discrimination, but we have not spent the appropriate time on discrimination based on these other protected categories. And on many of our campuses, because of the pressure on Title IX, other types of discrimination and harassment have not received as robust of an investigatory process and sanctioning. So we're pushing for the UC system policy to change and for there to be a leveling, because I personally see this as an inequity in policy and procedures sort of across the UC system, and we're working to correct that as well. We treat them the same at UCSF, but we'd like a standard established across the UC system.
Now that makes a lot of sense. I want to kind of go back to this issue of sort of the bravery and courage it takes to be someone who speaks up, whether that's in reporting some kind of harassment or speaking up in terms of activism, writing an injustice. You know, obviously there's still inherent risk for students and others to do that. And I'm wondering if any of you can sort of share ways that you see that students can maybe mitigate that risk, but you've seen be kind of effective. And I'll just open it to any of the three of you.
Well, I can start because I deal with a lot of these, the complaints once they come in, but there are many ways in which to advocate and to speak up. I think what we've found to be the most effective is this sort of collective voice, whether it be our registered campus organizations like the White Coats for Black Lives, or as a result of the racial uprising, we've had groups coming together across faculty, staff, and learner groups to send letters to myself, to the Chancellor about changes that they want to see, signed by hundreds of people, right? So you get a collective voice who agree to some specific issues that are of concern to them. And I think that provides one more sort of strength to the issues when you have that level of collective advocacy. And I think though there are also opportunities for this individual anonymous reporting of issues through our anonymous hotlines, which we have as well. And we've had students who say, well, this happened to me, but I need to match in that specialty. And I understand this notion of a hierarchy. Can you hold that investigation until I've matched in my residency? And then I'll participate in the process. And we honor that. We do recognize that despite the fact that the policies say that there can be no retaliation, there should be no retaliation, these are small circles. And so we do everything that we can to protect individuals from any specific repercussions as a result of bringing forward issues that have occurred to them.
Thank you. Xavier, Suneil, anything you want to add to that topic?
Well, just that as a faculty member, we are learning how to take advantage of some of the educational tools that institutions have gone through great lengths to develop so that we can understand the unconscious biases that we have and recognize our blind spots that emerge from those so that some of the issues that lead to these kind of cases can actually be avoided from the ground up. And, you know, taking the hopeful tone that, that sometimes people who are in positions of power do the wrong thing because they're unaware that they're doing the wrong thing. These educational resources that forward-thinking universities are doing a lot of work to create need to be really penetrated into the faculty pool more deeply. And I think that, you know, what I found from my colleagues is that when they may be reticent beforehand, once they start taking some of these modules, they actually find that they're really interesting, eye-opening, and they keep some of those principles in mind when they interact with their trainees, even though they're not really necessarily aware that they're doing so, and they find that those interactions go better. And so even the things that are under the radar that don't reach the point of you know, Title IX violations, et cetera, you can minimize the number of those situations and the percentage of those that reach the threshold where somebody might, you know, turn to the university and formally lodge a complaint. Those numbers go down. And so that's what I feel, what I see and what I'm noticing as a faculty member, at least at my institution.
It's great. I love whenever we talk about prevention as an effective way to deal with things. Xavier, I think you wanted to add something?
Sure. I mean, just one other thing I would recommend, particularly to students, is, you know, to hold the university accountable for the things that they put in writing. So, you know, if you have a concern, you know, linking that concern to a certain part of a mission statement or, you know, some sort of statement of support, some mass mail that comes out from university administrators. You know, we've probably all been flooded with these over the summer, right? Just to be able to, you know, root your complaint or concerns rather in language that the university has put out on its own, you know, to be able to, or even another resource you can think of are professional associations in your field or discipline. You know, again, they've probably put out statements, particularly again over the past few months, but those are probably happening year round, finding precedents to support your claim so that the emphasis is not just on, or the burden is not necessarily on you, but you can illustrate that, again, it is a collective action beyond just you. And obviously Renee's recommendation about the other students and faculty at your own institution is also very, very useful.
Right. I mean, there's been a lot of discussion this summer about more than words, right? A lot of people saying a lot of things, but then this next step of holding them accountable to live by those words. I want to go now to another question in the queue. Let's see where it went. That talks about, can we work to better integrate? Oh, I see, you already answered that. But I'll ask it anyway. How do we work to better integrate DEI and medical staff investigative processes to address comprehensively all aspects of a faculty member or medical staff member appointment with the institution? And I see she now answered that, but now you can just say it for everyone.
Oh, well, what I said in the chat was that there is some integration in with the medical staff's investigatory role and that of other parts of the campus community. However, the medical staff by state statute has the obligation to do evidence protected investigations of medical care. That's how we do root cause analyses and other things where incidents occur within a hospital setting for the purposes of improving care. If, however, there are violations such as sexual harassment of a patient by a provider, those are integrated and now shared with the Title IX office. And if there are other egregious acts by medical staff members that are also violations of the faculty code of conduct, then there is a cross connection with the faculty code of conduct process. So it's complicated. Many care related things are evidence protected and not shared, but increasingly other aspects of the professionalism of medical staff who are also faculty is shared more broadly across the campus.
Thank you.
Can I add something to that?
Oh, please.
Just saying from the faculty perspective that it's really interesting. I didn't know what the DEI module really included necessarily, but I did notice in our profiles apparatus for all faculty member who have their profiles that you can search through the internet, that some people had that little logo, next to their name saying that they had undergone and completed that DEI training. And the only two things that UCSF has in its profile section there is whether you're an alumnus of the university in one way or another, and now whether you have this DEI training. And I will say that perhaps it coincided with the current pandemic and some issues of racial injustice previously, and certainly the ones that have been going on that have engaged us in the popular culture more recently. People want that insignia on their profile page. And so the DEI concept can actually start catching steam, can start getting momentum. And this last round, they can't offer enough training sessions for DEI. Like I tried to get on it and I'm like 20 deep in the waiting list. And I looked through like 20, of these sessions throughout the rest of this calendar year. And they're 20 deep in the waiting list in every one of the sessions, maybe even more now. So it tells you that if you create a culture and you start branding even some of these DEI initiatives and create cool logos and show that there's a groundswell, that there's something that you're missing out on if you don't get on board with this, that you can galvanize the faculty to do these things that they might otherwise be really apathetic about participating in without that. So the DEI thing in particular, I think there's an element of that campus culture that you can change.
And that's the goal, to change the campus culture, to get people engaged. For the staff, it's part of the performance evaluation, and so that goes into how they get merits, et cetera. For the faculty, we've included it into the faculty merit evaluations as well. Those are the currencies of the things that we value, and this is something that we value. We're just trying to keep up with the capacity requests now, right? We're 5 years in with the champion training, and so we are, it's great. That's where we want it.
That's the kind of
changing a big ship to change the culture, or it's a school of fish and you get enough fish that change directions, you change the whole direction. So I like to think of it as we're a school of fish and we're going to get the whole direction changed by, getting a critical mass.
And it's interesting, like, whereas someone might have worn with the little hands logo that we have, at least at UCSF around DEI training, like a pin on their lapel.
Yeah.
Because we're not in physical space with one another right now, that little insignia on your profile page, that's like the pin on your lapel is the way I think about it. And so there's just ways to integrate these things in a fun sort of way into the community. And I think that other institutions can do similar things quite easily, actually.
I love that image of the school of fish. It reminds me of a childhood book. I forgot what it's called, where one fish starts doing something different and then they all change.
Right.
It's hard to believe that we're almost at the end of the hour. This has been such a fantastic discussion. I'd like to give each of you sort of like a lightning round, maybe 30 seconds just to share any final thoughts with the group. I'm going to go with Xavier first, and then Renee, and then Suneil, and then I'll wrap up.
Yeah, thank you. Again, I think that one major point that I just like to reiterate is that, you know, these issues, again, are a part of the work that we do as higher education professionals, as medical providers. These are things that are absolutely necessary, and they should be treated as such by our institutions as things that are absolutely crucial to the advancement of science, the advancement of medical care, and you know, we should not treat them as, you know, these bonuses, but really think of them as ways that move the conversation and our innovation forward. So, thank you all.
And Xavier, just to add on what you said, I completely agree that these are competencies that, in fact, you're not a competent healthcare provider if you don't have competencies in caring for diverse patient populations, working with diverse colleagues, understanding diseases and sort of the cultural conditions upon which groups and individuals live. Then we're not doing our job of really training the next generation of healthcare leaders, which is who we seek to be and what we seek to do. And ultimately, our goal is to alleviate suffering. And we have to see where the suffering's worse, and that's what we're obligated to really start to address. So it's been a pleasure. Thank you.
Yeah, and I'll also say it's been a great pleasure joining my colleagues and being a part of this. I think the way I would conclude is by saying that part of what medicine and biomedical research is all about is appropriate skepticism, because skepticism creates rigor, and rigor creates better testing, and better testing creates better knowledge, and so on and so forth. On the other hand, because of that, we tend to have a very skeptical community of people, especially the people who are at the upper echelons of what we consider to be our overall community. And when as I said at the beginning, when folks started saying that DNA has the genetic information, there were people who were skeptical of that, and they pushed back saying, no, the genetic information is carried by proteins. It could never be DNA. It doesn't have the capacity to do something like that. Well, of course, we all know that was wrong, and now our whole world is based, in medically speaking anyways, on the understanding of the gene and what it does. I think that we're at that point right now where some of the conflict that we're seeing and the push and pull that we're seeing in medical training and in the way we interact with the communities we care for has to do with this idea of skepticism. Oh, we can't possibly solve important problems using these approaches. We should be listening to more lungs and hearts and not necessarily worrying about, who all lives at home with the individual who's coming to see us in the office. And I think that that skepticism will be diminished by proof. And we're continuing now to prove that these principles are as robust as DNA being the carrier of genetic information. And once that proof permeates through our ranks, we'll see a lot of changes that come from that. And you're seeing us in that period of struggle right now where we're trying to accomplish that lofty goal. But I think we're doing the right thing by continuing to push.
That's a great note to end on. I think it's hard right now to find notes of hope in the time that we're in. I found this to be a very inspiring discussion. I want to thank our brilliant panelists for taking the time. This actually was the third in our summer conversations on speech. So we're wrapping up this particular kind of series. Next week, our fellows' research from their year-long projects will be released. And I think that's going to be incredibly helpful information for everybody in higher education. And then we'll be doing workshops along with those. So in the meantime, I just want to thank everyone for joining us. Again, thank our panelists, and of course, wish everyone everyone stays healthy and well, and we'll see you soon. Thank you so much.
Sure, it's a pleasure.